There are clinical scenarios where standard protocol dosing of vancomycin can cause more harm than good. Protocols are developed with good intentions. They are helpful. They are usually well vetted, based on guideline recommendations, and lay out an approach that will likely be successful for the majority of patients. But no protocol can account for every clinical scenario, which is why we must know when to stray away from vancomycin protocols. For a deeper dive into the limitations of vancomycin protocols, head over to pharmacology.com to access the full unit. Our first red flag is quadriplegia and paraplegia. Paraplegia refers to the paralysis of the legs. Quadriplegia is paralysis of both arms and legs. Always read the patient's history prior to dosing vancomycin. If quadriplegia and paraplegia, or really any spinal cord injury is documented, veer off the protocol. Here's why. Vancomycin dosing protocols rely on calculation of creatinine clearance as a measure of renal function to determine the frequency of dosing. Creatinine clearance is dependent on the body's production of creatinine. Creatinine production is dependent on the muscle metabolism of creatine. In paraplegia and quadriplegia, the inability to move those muscles results in muscle atrophy. Muscle will waste away. In paralyzed patients, serum creatinine is low not because of excellent renal clearance, but because it is not being produced by their damaged muscles. Using creatinine clearance as a marker of renal function in these patients will lead to an overestimation of renal function and can mask the presence of renal dysfunction, leading to vancomycin accumulation. A calculation cannot discern this difference. We must be able to recognize the risk and adjust our calculations and our dosing. Extend the vancomycin dosing interval beyond what the calculated creatinine clearance suggests in patients with paraplegia and quadriplegia. Most times, you will calculate that they can tolerate Q8 dosing. I assure you, they cannot.